I'd like to welcome everybody to the webinar presentation. This is actually our second presentation of the day. Some days we're running two, some days we're running one, but we are definitely putting forth a solid effort to maximize the use of this time when there's more time available to most of us to be able to provide education and give everybody more tools to put in their toolbox so that when we get back to work, we'll be able to return more educated, with more capabilities and more tools. I am Michael Saltzman, and I'm the Director of Digital Products at Blue Sky Bio. I hope everybody is staying safe, staying healthy, and staying at home during this time period. And we're continuing with our viral dental education webinar series. Most presentations are 1 p.m. Eastern. If we do a double header, then we usually have one in the morning and then a follow-up at 1 p.m. Eastern. Our schedule is still changing and we continue to add additional webinar presentations. So check out blueskyplan.com/webinars 2020 and 2 Facebook groups, the Blue Sky Bio user group and the Viral Dental Education group as well. CE credits for everybody who's attending live will be sent automatically to your email address. You don't need to do anything. We'll send it to you directly and automatically. And if you're watching this recording, then please complete the 10-question multiple choice test so that we could go ahead and send you the CE credit. For this presentation, we have the honor of hearing from Dr. Michael Scherer, who will be presenting on the topic of avoiding rookie mistakes, more of a case review and virtual study club. So as usual, if you have questions, enter them into the question and answer box, but please don't hesitate to submit the questions. We want to have this presentation be more interactive. Here are the questions, and Dr. Scherer will be able to address them and answer them. Just in a nutshell, I'd summarize our relationship. First of all, Blue Sky Bio and Dr. Scherer have had a relationship for quite a while, for many years now. I would simply say that he's both an innovator and an educator, maintains a tremendous amount of different educational channels, both digital, online, offline, live, remote. Really amazing effort, greatly appreciated by the dental community, providing a tremendous amount of dental education. So Dr. Scherer, if we could first of all welcome you. Thank you very much for presenting today.
Michael, thank you. And that was a very kind introduction. I'm both honored and humbled.
And if we could start off before we get into the presentation, just a little bit of a discussion. It's always interesting to hear how educators are using this time period, what they're using the time for, and how they're able to kind of see the silver lining in the situation and take what's possible from this difficult time period.
Yeah, you know, certainly this is just an immense change in all of our lives. And I know for many of our fellow dentists, implantologists, and folks that are significantly involved with dentistry in the past 2 years, your own practices, we've been just running. It seems like the economy was just going crazy and everybody was just running. And then all of a sudden, just like the instant brakes have been put on onto our practices and our schedules and things like that. And, we kind of approach it in 2 different ways. We can either just sit on our couches and watch Netflix, which is totally cool. There's nothing wrong with doing that. And then on the flip side, we could always just spend a little bit of time to kind of reinvest in ourselves. And, I've always been the type of person where it's like, after, probably 7, 8, 9 o'clock at night, man, I got to sit on that couch because I am just like spent. So during the day though, I find it a little bit weird because, normally I would just be seeing patients. But yeah, I'm spending a little bit more time, especially playing with software and even teaching myself a little bit more stuff that I've always outsourced before, like RPD frames and designing full arch cases and learning a little bit more as we go. And, I'm presenting here from my laboratory at my office, which normally I present from home or do different things. But yeah, on my schedule today is I got to see 1 emergency patient. So I've been seeing, I think, maybe 4 in a whole week. And these are like true swellings and emergencies, things of that nature. But come in, I'm like, all right, I got to go to the office. Let me at least play with some zirconia and teach myself how to stain and glaze, which I kind of suck at. So maybe I can work on some of those things that I've always wanted to work on. And, for many people tuning in, it's a really neat opportunity where we get to take, a little bit of education, especially with the amazing support of Blue Sky Bio, to be able to offer this free education where we can just sit around and just almost have like a study club. And in many ways, this is emulated off of a study club that we would do with doctors and attendees in a non-COVID world. So what an awesome opportunity, and let's use this time effectively.
Okay. Another question before we get started is, as a digital master, we were talking previously right before the webinar presentation, how you have a tremendous amount of different digital dental toys and apparatuses and hardware and software. What would you identify as your favorite? Let's give you one hardware and one software tool that you're using.
Oh man, Michael, that's like asking me to try to choose between my children, So the challenge is that, I do get that question a fair amount, which is, what is my favorite toy? What could I not live without? It's really hard to say. It just depends upon the clinical procedure. I would say probably the one tool I couldn't live without with being in implantology is my cone beam machine. And that seems to be pretty consistent across the implant world. I could use alginate and PVS, even though I hate it, but I could. But you can't really, in my personal opinion, do really effective implantology without a combing machine in your office. Yeah, I can outsource. I could send to a combing machine, but I probably couldn't live without my cone beam. And there's a lot of great cone beam machines out there, including many of those that are sold on the Blue Sky Bio website. So I encourage everybody to go check that out. That would be kind of where I first start. Of course, I'm impartial to digital scanning. And me personally, in my restorative practice, I cannot imagine I'd probably give up Crown and Bridge dentistry if I had to go back to using PVS. I know people say, oh my, that sounds so conceited when you say that. Yeah, well, maybe a little bit. I mean, honestly, the thought of pulling out a triple tray and making an H&H impression I just go completely crazy, the thought of that. So intraoral scanning is a huge part of my every single day methodology. And it's not just, oh, well, the cost of a PVS impression or a cost of a cone beam, man, we got to ROI this and figure all that. I get that. In my opinion, there's a lot of X factor stuff where the patient is sitting right in the chair, especially as we're ramping up now in a potential post-COVID world, where a patient says to me, they come in, they've broken off a tooth, and they say, doctor, what can I do about this? I say, well, unfortunately, the tooth might have to go upstairs. Might have to go to heaven and take the tooth out, whatever analogy you want to use. And the patient goes, oh my God, what am I going to do? Well, here's some options. And I show them the implant model and they say, wow, doctor, that sounds great. Well, when can I get started? When a patient says, when can I get started? My personal opinion, the only real good answer to that is, how about now? Especially in a post-COVID world, because before COVID, it was like, well, we're so busy, I can do this. But I anticipate in a post-COVID world, especially my practice, since I'm totally shut down, other than just a couple, like 4 or 5 emergencies per week. In the post-COVID world, we're gonna need to be a little bit more nimble. Our schedule is going to be a little bit slower. So if a patient says, when can I get started? How about right now? I got time. Let's just go make a cone beam, make an intraoral scan, or snap a quick alginate, and then that way we're ready to rock. So it's that X factor thing of digital technology, and 3D printing and milling is a part of that. And I've long ascertained that, going deep into the swimming pool, just jumping right into the deep end, is a little bit risky and fraught with perils. I like tiptoeing. Maybe that's just the conservative side of me. So there's nothing wrong with PVS and alginate, folks. Nothing wrong with that, even though I'll rail against it on social media, and some of you know I will. But the reality is that it's all how you perceive it. So in my hands, I love having complete control. But then again, as I was mentioning earlier, Michael, I'm teaching myself how to do some milling. Oh man, I got to tell you, here, I'll show you a couple things. So it's not that often I get to present from my office. Literally, this is the crap that pisses me off. So here I am, teaching myself to do milled trilor and angled screw channels and all this. And I went through 2 pucks and 2 burrs. I'm breaking these things, and this is probably $700 worth of materials and burrs and everything. And I'm saying to myself, well, Mike, maybe that's not so smart. Even me, it's like, I know this technology pretty well, but I'm still learning every single day. So you know what I did? I took that case and I outsourced it, and they milled the titanium frame for $299. I'm like, oh man, I should have done this. So I'm learning every single day. So, you know, we can be smart about it. In the post-COVID world, I think we'll need to. And I think that's a very valid question. So I know everybody wants to, you know, say, Mike, just tell me what scanner to buy. Tell me what cone beam machine to buy.
That's
And
exactly the questions that are coming in now.
okay.
Which scanners and which intraorals?
Honestly, everybody, just go. Well, I would normally say go to the trade show and just find out what works well in your hands. You know, obviously in this crazy world, it's a little hard to go to the trade show. I would encourage you, first and foremost, as a shameless plug to Blue Sky Bio, I would just go to the Blue Sky Bio website, and whatever scanner that they've got on there, you know, it's been validated and tested. You know, Corey does an amazing job with you guys. Baron, everybody does an amazing job with getting these systems validated, and the scanners that are on the Blue Sky Bio website are awesome. You know, in my practice, I currently have a Trios, a Medit, and a 3M True Definition scanner. And I do use all of them, maybe not every single day, but on a fairly routine basis. And all of them are pretty awesome. So I'm just correcting my camera. You know, it's becoming to the point where the research is showing all intraoral scanners are equally as accurate. All intraoral scanners work, and you can even use intraoral scanners to scan stone models. So the reality is that the water is nice. Everybody just jump right in, find something that you like, you know, find something that works in your hands, find the right price point for you, find the right features. Historically, the market's usually been, you know, CEREC, Trios, and then others. So that's kind of historically been the market. But you know, if you do a lot of ortho and you do a lot of your own ortho cases, iTero is a good scanner. Medit's an amazing scanner, especially for the price point.
Amazing. Okay, great. So I guess let's get started with today's presentation.
Awesome. And everybody, this is meant to be kind of like ready to go. I'll slide share.
Yeah, go ahead. Share your screen.
Cool. So this is meant to kind of be a very interactive session here, everybody. So feel free, throw a few questions in there. Let's just have some fun, just to make sure that we kind of cover the right stuff, and to make sure that we can give CE credits, you know, for PACE and everything like that. There are some materials that we will cover that is just a little bit of a review from some of the things that I talked about in a presentation a couple of years ago. It's still on YouTube for Blue Sky Bio, called Avoiding Rookie Mistakes. So the formal presentation's on there. A lot of those things on that presentation are still good and valid and everything like that. So I encourage everybody to go ahead and check that out. So this is meant to be like a study club, and we'll just kind of finish whenever we finish. So that way we just have some fun. If anybody wants me to kind of answer specific questions about cases, but I'm going to take you through some real cases and how I would work them up in my practice. But here's a little bit of information about me. I'm full-time clinical practice here in Northern California, only about 2 hours east of San Francisco. But I have university affiliations as shown here, and my website is michaelscheerdmd.com. Also, just a quick disclosure statement. Any information I present is not on behalf of either institutions, and Blue Sky Bio recommends the use of a CBCT and or laboratory desktop scanner to produce STL files. Intraoral scanner STL files is not an approved pathway. Just a quick disclosure. So I certainly acknowledge, again, thank you, Michael. Thank you, Blue Sky Bio. And I encourage you to check out my resources as well. My website, michaelscheerdmd.com, publications, and I have 5 YouTube channels. Additionally, connect with me on social media, Fast Track Dental CE. And just as a quick little shameless plug, if anybody's interested in learning step-by-step guided surgery protocols with a billion different ways of doing it, featuring the Blue Sky Bio software, make sure you check out this website, learndental3d.com. And there's a webinar coupon code for anybody tuning into this BSB webinar. So it's for the first 100 people only. Okay, so let's jump right into our first clinical case. So this is a patient, that same analogy that Michael and I were talking about just a few moments ago, you know, in this technological world of where we're kind of looking post-COVID, let's Imagine we have a situation where a patient comes in, cracks off a tooth, and he just completely shears off, not shearers, but shears off the cusp off. Oh, sorry, that was too much. Shears the buccal cusp off of tooth number 5. And for our international attendees tuning in, this would be tooth number 1, 4. So it's a first premolar, just completely shears off the buccal cusp. Sometimes it's the lingual cusp. I don't know about everybody tuning into the study club here, but it seems like my number one implant is either arguably like a first molar on the upper or lower, but also toe-to-toe a maxillary premolar or bicuspid. Why? Because you can see a patient who looks like this on the upper left of the screen, these big MLD amalgams, just a matter of time before you have that kind of wedging effect. It just goes, one of the cusps just completely breaks off. So this is a great case of where we're kind of like, let's like get started with Blue Sky Bio, with the software, with doing guided surgery, just because this is a wonderful case of using the fully guided kit for Blue Sky Bio. So we'll go through this case live. But the general idea here is that, you know, in my clinical practice, it would make an intraoral scan, make a cone beam scan. And the patient says, when can I get started? How about right now? I roll over my intraoral scanner, which is on a cart. You know, I'm a big fan of carts because they're on, fully powered up. Windows updates are done for the day. We're not waiting on something in a cabinet and an assistant to say, well, let me go plug it in. I'll start it up. You've already lost the patient if it takes more than 2 to 3 minutes to get your scan. And sometimes this happens in a hygiene appointment where we just want to go ahead and just make a quick scan. The hygienist is going, come on now, we need to get going, etc. So we make an intraoral scan. All right, no problem. I'm going to walk out the room, go see my other patient, but Tanya's going to take over. She's going to do the cone beam scan. So make a cone beam scan before the patient leaves. They go up to the front. Everything has already been worked up for our entire case. So now our next appointment is implant surgery. So the general idea is we're going to go ahead and utilize our fully guided kit to go ahead and place our dental implants. And, you know, I'm a huge fan of using the fully guided kit sleeveless. Even though metal sleeves are a great idea, it's a wonderful thing to use in your practice. And the neat part is you can use the fully guided kit with any individual implant system, and whether it's Max or internal hex or another implant system, you can totally use sleeveless. And just got a quick question here as well. This is totally interactive, everybody. So I got a question here from Julie. Why do I prefer sleeveless? I don't know, man. It's just, number one, it's just, I print the thing and I cure it and I'm done. I don't have to put a metal sleeve into the surgical guide. I don't have to worry about glues. I don't have to worry about adhesives, things of that nature. And then addition, sort of some of the X factor thing is that the guide tube can be a little bit smaller. So in a case like this, you'll see it when I design it live. I run into an interproximal space constraint issue. So the fully guided surgical kit from Blue Sky Bio has a certain diameter for the tubes. And since this is a virtual study club, I got my little measuring tool, and I'll pull out my Blue Sky Bio fully guided kit. And one way that you work this is you just grab whatever drill. So this is the 3 6x6 drill, and I'll take out the 3 6x6 drill, and I'm just going to take the drill and just kind of put it into the tube portion of the actual template. And this comes out to be right around 4.9, 5.0, somewhere in that neighborhood. So the idea is that I can go ahead, as long as my guide tube is a little bit bigger than whatever this little cylinder is, that will essentially occupy the space of your trajectory control, because you have two different things that we have to think about with guided surgery. Number one, when the drill goes down, it's got to go through the tube, and then that contact keeping your drill straight is what's going to control your trajectory or angle. And then in addition to that, you have to worry about depth control. And a lot of times with other guided kits, they have, one drill for each diameter, but then you size your tube higher and lower based upon how deep you want to go. But the genius part about the Blue Sky Bio fully guided kit is that I just choose my depth control by choosing the length of the drill. So if I'm going to be drilling 6, 8, 10, 11, 5, or 13, I just grab the 13 millimeter drill. So this particular implant we're doing is a 13 millimeter long implant. So, the software makes it so freaking simple with this particular type of guided kit that I don't even have to think about my depth control if I'm doing it sleeveless. It's just really, really cool. And that's still the same if you're going to use a metal tube. So you just have to train your eyes to go ahead and know it. Now, yes, Blue Sky Bio and a lot of the training videos recommends a certain amount of what we call offset or prolongation, but in theory, you don't have to worry about it as much. So it's a much simpler design to kind of give you a short answer to the reason why there. And plus, you don't have to worry about thin areas of 3D printed resin that might be unstable. We had another question here from, I might apologize for the pronunciation of your name, Mufid. Is the guide milled or printed? This is a printed guide. I personally think that milling for surgical guides is just silly, completely ridiculous in my personal opinion. I know there's a reason for it. For some people, they love the fit of them, but man, milling is such a waste of material and time. It's a real pain. And with 3D printers being so affordable as they are, just start printing your guides. We had another question here from Monica. How long does it take to make the guide? Depends on your printer. This particular one, I think, was on my Formlabs printer. So this guide probably took about an hour and a half to print. With the Sprint Ray Pro and the Moonray 3D printer, they're much faster since they're DLP technology. So with the Sprint Ray Pro, that might have been like a 45-minute to 50-minute 3D print, somewhere in that neighborhood, depending upon how you print it.
Which printer is your go-to printer, and which one would you recommend for a dentist looking to buy a printer?
Yeah, that's a good question. What's my go-to printer? I have 9 3D printers. I've probably purchased about 20 of them in my years, just because I'm a freak. But that being said, that's an easier question to answer because surgical guides, yeah, you can go out and buy one of these like $300-400 3D printers, like an Anycubic Photon or a Frozen, things of that nature, and they work pretty good. But the analogy I like to give is this. Are you looking to purchase something that has this little like fruit logo on it? It's hard to see on the screen, but there's value in spending a little bit more money on something like Apple iPhone, because I enable the calendar sync by clicking a button that goes, and all of a sudden it pops up on my Mac computer, which I don't have one, but if you did, it would pop up, or on your tablet, etc. Versus how many of us feel comfortable with syncing our iPhone to our Android tablet and our Windows PC, and the calendar syncs perfectly. So that analogy is true. So you can save some money by just buying off the shelf, non-connected things. But there's also some value in saying, okay, I'm going to spend a little bit more money and buy like a Moonray or a Sprint Ray Pro 3D printer, where you can literally just drop your file directly into their software and it prints every single time, pretty much. So what happens is that for surgical guides, it's really hard to beat 3D printers like the Sprint Ray Pro or the Formlabs Form 3. Those are just really go-to printers as well. So both of them are amazing. I won't say which one is better because I think they're pretty much both pretty awesome. Just kind of depends upon what you're looking for. I would say if you're only doing surgical guides, you can't go wrong with either printer. If you're doing surgical guides plus something else, like you want to print NextDent resins, or you want to print Keystone Splint, which is amazing, Sprint Ray Pro would probably get the edge there because it has a lot more open resin modes than the Formlabs does. So that's a great question. Okay, let's go ahead and this resin, by the way, okay, we had a couple more questions. This one's a great one, Nuriel. How do I encourage patients to go through guided surgery? I don't know. I just tell them, I say, listen, they don't even think about it. I don't, part of what I've done is kind of silly, is I started printing my own guides, and I used to charge a lot for my surgical guides, like $300-400 for a surgical guide. Then I would have to sell it to patients like, hey, look, you're going to go ahead and you're going to get this incredible benefit. And oh my God, it's amazing. To tell you the truth, it's all whatever. Patients don't want to pay for it. So if you're placing your own implants, which is the big delineating factor, if you're placing your own implants, I stop charging for my guide. Why? Because my guide costs like $20.
You give the patient choice, or do you pretty much dictate that you're going to be using guided surgery?
Nearly 100% of my surgeries now are guided. Of some variety. And I'm a firm believer in it. I think guided surgery is infinitely better, more precise. And if I were a patient sitting in a chair, I'd want it at least some sort of guide. Now, qualifier. How many of those surgical guide cases are fully guided, like this particular case? For my extraction cases, everybody. Like in this particular case, nearly 100% of the time of my immediate extraction implant placement cases are with a fully guided kit, like the Blue Sky Bio fully guided kit. Why fully guided for those versus if I'm going to do just like a everyday implants, or number 19 or 30, whatever, it's a healed site, whatever, or a maxillary case or an overdenture case, etc. Those cases will be probably about 90 to 95% with either only 1 or 2 drills, meaning my pilot or partial osteotomy guide. Why the delineation there? I like a hybrid guided freehand protocol. The reason for that is that 80 to 85% of your implant placement is done with the initial guide. So if I gain that and I get that advantage, open up a flap after, and then I can look at my osteotomy and say, wow, okay, you know, it looks perfect, or 90% of the time it'll be perfect, but maybe 10% of the time it might be off quite a bit. It's hard to say how that happens. And that's a big thing in terms of the avoiding rookie mistakes. If you tune back to the presentation, which I'll cover a couple slides here in a bit, there is a fair amount of potential of inaccuracy of your surgical guide. You can be precise with your surgical guide, but you can be fairly inaccurate if you're not careful. So the reality is guided surgery is amazing, and I use it for nearly 100% of my cases. And why do I use fully guided more for extraction cases is because I can see the socket right there. As I'm drilling, I can verify that the implant trajectory is going to go according to my plan, not according to the root socket, which is critical because when you start drilling in sockets, the drill just goes, meow, meow. So guided surgery makes it incredible for those. Now, that being said, if you've got bone that's super wide and it's like 10 millimeters wide, I'll do the case. Definitely fully guided, maybe just do a punch. And I don't know, I've kind of stopped doing punches, everybody, because you lose all that keratinized tissue. So most of my fully guided cases, I open up a small envelope release and then place the implant basically fully guided in those predictable cases. So that's a wonderful question. And a big part of how I avoid some of those mistakes in my practice is if you've got those cases where, you know, it's a pencil thin ridge versus a ridge that kind of looks like this, you know, that's going to be a big difference. This is not the case you want to do your first guided case on. This is the case you want to do your first guided case on. And it really, really matters. So let's go ahead and take a pause on a couple questions, and I'll cover some more questions as we go into the case planning for that. Does that sound okay, Michael?
Yep, sounds great.
All right. So let's go through this case. And ultimately, the reason why I liked guided for this particular patient was, I mean, in extraction premolar, it's like, if you need a surgical guide for these, come on, this is silly. But the reality is that I do guided surgery to enhance my prosthetics. Enhancing the prosthetics is key, because if I can verify that my implant is right in the center of where my crown is going to be, it makes for a much more predictable type of restoration like this. Even though this patient's a bruxer and a grinder and everything of that nature, it was very, very predictable for me to go ahead and do the guided case here, even though I could have nailed this. But the reality is that it puts the implant exactly where I want it. So let's go through the case. So I'm going to go ahead and shift modes here as well, kind of bring this down. And what I'll do is I'll kind of open up my Blue Sky Bio software. And I've got here a folder on my desktop of some of our patients and things of that nature. So we'll start with patient RM, which is that first patient. And again, as questions come in right here, everybody, I'm happy to answer them. I'm just going to be doing a case live and things of that nature. So that way it could be a learning experience for everybody. As I open up my Blue Sky Bio software, it's going to go ahead and ask me what type of case I want to do. And some of the latest features of the latest Blue Sky plan is amazing. So again, I better close out my emails. I need to get some of those crazy emails coming in. So when I open up my Blue Sky plan, since I'm doing a surgical guide, I'm going to left click here on surgical guides. And then I already have the CT files ready for this patient, or I also have the case completed. So I'm going to go ahead and click on import patient CT scan. And when I do that, it's going to be patient RM. So I've already put him into the folder. So the idea is, this is that after I make my scan, uh, it creates some folders. In my computer on my Combi machine, I export the DICOM files from the internal machine, which I have a Vatek green, but I export that from the Vatek software into my network folder on my at my office, which I've copied over that folder here to the desktop. So this is the DICOM files. And typically you want to see usually a few hundred of these, maybe about somewhere between 200 and 500 of these DCM files. That'll mean that you've got everything proper. And in addition to that, I've got right here the intraoral scan of the patient's teeth. And this particular scan was made on my Trio scanner. So I'll show you what that looks like. Here's what his scan looked like, just with this kind of like simulated laptop looking thing. And right now you can see here that, the patient's cracked off the teeth, but I've got this kind of tooth here left over. So now what you can do is go straight into your Blue Sky Bio software, and I'll open up the DICOM files. And then that way I can go ahead and see I've got our DICOM files, and I'll have to anonymize it. So I apologize there. Patient name, just go for a moment. Bring in the scans, and then it's going to go ahead and ask me, do I want to go ahead and do anything here? And also, just as an important little thing, just for everybody tuning in, this is an important step in the Blue Sky Bio software. And using the topic today about avoiding rookie mistakes, there's not too much you have to do on that first screen, but on this screen, if you've ever made a surgical guide where you're like, man, it's really blocked out on the front, or maybe it's blocked out too much in the rear, that type of thing. Blue Sky Bio does set a lot of the path of insertion of the surgical guide here at this stage. Ideally, I'd love to see it someday shift more towards when the surgical guide was designed. But if my cone beam scan looks like this, because my patient was leaning pretty forward, I want to correct that. So that way the occlusal plane, which is this line right here, the occlusal plane is roughly parallel to this yellow line right up in here. I don't really like to do this. I just leave the scan fully as is, but I'll also verify that this occlusal plane, if this were like the curve of Wilson or whatever, and this is the curve of Spey, the occlusal plane should be horizontal to this yellow line here, and from an AP direction, horizontal to this line here. So that's an important step here that I do in every case. So then right in here, we go ahead and give it a few moments to let it load up.
So let me just comment that your comment about the insertion path is coming soon.
Oh, I'm so excited about that, Michael. That's amazing. That's a huge thing. And when that comes, that'll be fantastic. So thank you. Okay, so once it pulls up here, I'm going to go ahead and choose import STL model, or if I have a CT scan of the impression, you can do this here. So this is kind of a newer feature of Blue Sky Bio software, which is amazing. This makes a very, very simple surgical guide plan. And then also CT scan of impression with markers, or CT scan of denture, or scan appliance with markers. So I'm going to left click on import STL file. I'm going to bring up our file. And now we have a situation where we look at this and we've got one STL file straight from the machine. But what I did in Mesh Mixer is I just did a virtual extraction in Mesh Mixer. And you can do this also in the Blue Sky Bio software. It's completely up to you. But I just have it prepared so that way it kind of make for our process today a little bit easier. If anybody would like to kind of see me go through the Mesh Mixer steps, I can. I'm happy to do so. Click the OK button. So once I click OK, this is not a newer feature, but a very welcome feature of the Blue Sky Bio software. So if you still have an older version of the software, this came out a year and a half or 2 years ago or so, or maybe it wasn't that long ago. But when Blue Sky Bio announced automatic registration of the cone beam scan, I just basically click on Maxilla, click the OK button, and it goes boom. And it automatically aligns. And that's huge in my personal opinion, because the alignment of the STL optical scan from the optical scanner is a huge potential source of inaccuracy of your surgical guide. And the more that we can automate that, the better. And that clearly is the case here. So hopefully I didn't screw this up. I grabbed the right patient, the right scan. Sometimes my computer, we're over Zoom, just taking a little bit of time. but it should auto align pretty cleanly. Give it a moment. In the meantime, I can answer a question or two. What computer do I recommend? This one here is from Raul. What computer do I recommend? Windows or Mac to manage your scanners and all the 3D software? Blue Sky. Which model you recommend? Specifications, etc. I really just recommend any laptop that's a quote gaming computer, and buy just whatever the cheapest one that you really want to. Frankly, I can make an argument you buy the most expensive that you can afford, because typically as you go up in cost, it goes up in quality usually, but not always. Usually the sweet spot's right around somewhere between $1,000 to $1,500 US. If you're in the States, just buy it at Costco. Costco's got great computers and laptops, or you can just go on Amazon or on Best Buy and buy it there. If you're international, go to your local computer store and just say, hey, I want to go play like World of Warcraft, or like, I don't know, whatever the games are right now. I want to play a video game, or, what can I do? And here's my price point. So do I like Windows a little bit more over Mac? I do, just because most CAD software works a little bit cleaner on Windows than on Mac. But you can use a Mac pretty well, especially if you install Windows on it. Mac hardware is awesome, but it's very, very expensive. So really, there's so many different brands. I personally have a laptop called a Lenovo P1. I kind of tricked it out. It's got a Xeon processor, 64 gigs of RAM, 4 terabytes of hard drive. I'm kind of a pack rat, but I like computers, and I really like a lot of horsepower. I do a lot of video editing. I do a lot of CAD design and everything like that. So, but in my office here where you are, I turn the computer, also I'd probably screw it up, but right next to me, right over here, I just got a little Dell Alienware desktop, and I bought it like on a Thanksgiving sale for like $850. And it's a workhorse. And it's got a NVIDIA 1080 chip in it, so it's like a steal of a lifetime. So I just bought it. Okay, so once this is aligned, I click the OK button, and now you can see here the green model alignment is really nicely aligned. So this is important for us to talk about. And let me just take this for a second. I just need to go ahead and delete this. That way I can pretend like it's HIPAA. So now this is aligned pretty well. And this is an important aspect of the workflow, because the alignment and where things can go wrong. Let's just take a kind of a segue for a second, because guided surgery is very precise and predictable, but guided surgery is only moderately accurate. So where some potential errors can occur, and this is slides from a presentation from an earlier YouTube presentation. Cone beam scan, your calibration of your cone beam, voxel size settings, importantly, patient movement. If you notice double movement on your cone beam scan, be careful. You can use that to plan an implant case, but if you have any movement, you're drastically potentially decreasing your accuracy. And then, of course, positioning with the cone beam scanner. I want my patient to be horizontal as much as possible in the cone beam. Also, I want the position of my potential implant site to be right in the center of that cone, that disc, because the research does show that, yeah, cone beam CT is pretty darn accurate, but it's also a little bit more accurate as you get closer to the center, just the way that photon beams work. So in theory, what I do in my office, my assistants go ahead and put the patient, if I'm doing a maxillary case, they position the maxillary arch. That way it's going to be in the middle of the potential cone beam scan. You can do that with your cone beam machine. It's also important to have a pretty accurate stone model or optical scan. And then additionally, you have to be careful with your intraoral scanner choice. One question, I keep getting a couple of questions here in the question box, what scanner is more accurate? What scanner is more accurate? Folks, all intraoral scanners are accurate enough, okay, for most of what we do. And it's interesting because, if you ever work with a cone beam scanner lab where you send out for surgical guides, every now and then you'll get a thing saying, hey, something's not right, something doesn't fit. Chances are it's not necessarily your optical scan. I hate to say that. Chances are it could be the way that the cone beam scan was made, or excessive scatter on the cone beam scan. So look back at your cone beam scanner. That's usually where I recommend a lot of doctors, clinicians, and technicians to kind of look at, because inaccuracy of the cone beam scanner is a significant factor. And it's not necessarily that you have to calibrate your scanner every day. Now, most scanners these days, the modern scanners, you don't even really need to calibrate that much anymore. It's about how you scan your patient, how you scan with metal in their mouth, and then how you position the patient is absolutely critical. So also make sure that your planning is correct. Your software's choice is key. Blue Sky Bio has been doing this for a long time, so they have really great controls. So you don't have to worry about the Blue Sky Bio software. It's usually the user doing something more than anything else. Your manufacturing method, question came up earlier about milling versus printing. Make sure that your 3D printer is accurate. If you're using an everyday printer like a Formlabs or a Sprint Ray or an Extent printer, a Sega, things of that nature, those are all really accurate scanners. So you don't necessarily have to worry about that. But milling could be an issue if you don't have your milling calibrated, or if there's a lot of undercuts and your CAM software doesn't get those deep undercuts. Folks, I know it sounds silly. I know I get ripped on social media when I say stuff like this, but it's true. Just print the model. Mill the guide, print the guide, and print the model. Spend an extra $1.78 to $2 and print the little model so you can take the surgical guide and fit it onto there. Let me see if I got one here. Hold on. Well, shoot, I don't have any models sitting around. I should have had that ready. But the idea is that when it comes straight out of the printer, okay, we also have to think about the orientation of how we're printing our surgical guides, either vertical or horizontal. That can be an issue. And when I print the model to go along with it, I take the model and I just fit it on top of the surgical guide. 95 to 99, maybe 99.9% of the time, it's just going to fit right in, okay? But what if it doesn't? Then you have to adjust it in the mouth. If you're doing a sleeveless surgical guide, like in this case, you don't really have to worry about it. If you're taking a metal tube though, and you're placing a metal tube into the surgical guide, having the model is important, because when you have the model, I can take the guide, put it on, even though the guide's going to fit because it was blocked out properly in Blue Sky Bio. But when you put the metal tube in there, sometimes the little edge of the metal tube is going to be sticking through the surgical guide. A lot of times when it happens in that case, I'll take the surgical guide and grind it back. So let me see, I have a couple of pictures of that. Let me see if I just grab that here for a second. I'm just going to pause the sharing just because I need to pull up a patient record here. And I'll take a couple questions, Michael, if we have additional questions here while that comes up.
You know, a little known feature or less known feature is you could actually write, if you left click on the patient's name in the top of the 3D view, and it will disappear.
Oh, awesome.
It actually, if you're presenting, that's a great trick to know about. There's a question that came in about patient sample data, and I'll just comment that we have on blueskyplan.com. If you click into any module category, you'll find educational information, and you'll also find sample patient data sets. So you could download them and start playing around with them in the software.
Awesome.
Do you want to field some questions now, or?
Give me just a moment. I'll show this thing while we're on it. So when I'm taking this tube, okay, and I'm taking that tube and I'm popping it into the surgical guide, this part's important. Flip it over, because a lot of times that tube is going to be taller than the resin itself. And a lot of times I will take a handpiece and grind that excess tube back, because when I do that, I then take it to the model. This part's critical. I know it's silly printing the model, but this helps avoid a huge potential mistake, which is the guide not fitting. So when I do that, it allows me to sleep well at night before the day of the surgery to say, okay, now I know everything fits. Okay, now you say to me, well, what if your model's not accurate? Chances are, if you're using any of those printers that I mentioned a few moments ago, the model is going to be pretty darn accurate. So now you can use this and just kind of verify that with your windows. Always put windows in your surgical guides if you're doing a two-supported guide. That will help you also avoid that error. So that was great as well. So I'll take a couple more questions, Mike.
Okay. The tolerance do you prefer between the drill and the guide tube in case of a sleeveless guide? How much tolerance do you leave between the drill and the printed hole?
That's an excellent question. Typically, I recommend somewhere right around that 0.05 to 0.1 millimeters of tolerance between any sort of drill, metal tube, things of that nature. It just depends upon you. while you're getting started with surgical guides, one really great way of avoiding mistakes is just to print a ton of guides and then literally to have your surgical guide. Oh man, I'm dropping things. Your surgical guide kit out. Then I'll take my tube, okay, or I'll take my drill and I'll pop it in here saying, okay, how does that feel? Does it feel loose? Does it feel tight? I want it to be a little bit on the loose side in the laboratory, because when you go to the mouth, you know, the patient's going like this, you're going like this, you got water, the assistant's tugging on things. So I tend to say putting it a little hint on the looser side. So when I'm doing a sleeveless surgical guide, like for the Blue Sky Bio system, me personally, I like a guide tube diameter of 5.15 in the software. So that basically gives you 0.1 to 0.15, maybe even a little bit more of tolerance. And I just like a little bit extra wiggle, because in my personal opinion, it gets you most of your trajectory, but it doesn't lock you in. You have to be careful also, everybody, especially with a sleeveless surgical guide, that you don't use everyday drills. So you don't use a drilling system like from Nobel Biocare or 3i that has a 3i, not so much, but some of the other systems that have a cutting drill itself. So case in point, I got one sitting right here. Say I had a pilot drill kit, and this is just a simple pilot drill kit right here. This one right here is this one's the Pal Top. Blue Sky Bio also has a couple of drill things, like the drill NSS, drill NSL you can use. This is just one I had sitting right here. This is a cutting drill, so I wouldn't want to do this one sleeveless. I would always want to make sure that I have a metal tube or metal sleeve for that one. So that was a good question.
Okay, another question that came in is, if my lab will print a $50 surgical guide, is it still worth buying a printer?
Totally up to you. That's a great question. The one thing I can never do is tell you what your time is worth. The key is that what's your time worth away from your family, in between patients, coffee time, that type of thing. In my personal opinion, you know, I just don't even think about the ROI cost of guide, number of guides, ROIing the printer and resin costs and all that stuff. It's for me, when I'm sitting at my desk looking at the schedule tomorrow going, oh no, I've got a surgery tomorrow. Shoot, I forgot to send out for the surgical guide. No big deal. Jump into Blue Sky Bio software, design the guide really quick, print it in less than an hour, something of that nature. And you know, even if you miss out on a single implant surgery because you forgot to send to that lab, in my personal opinion, you've lost the entire ROI for all of your surgical guides you probably have ever printed. That's just my personal opinion.
I want to jump in here and mention labpronto.com for dentists that do want to outsource, either because they're just getting started or they want extra help treatment planning, or they don't have a 3D printer yet. Labpronto.com is a fantastic solution to get the digital work done, either the digital planning or the actual physical fabrication. And what stands behind LabPronto is a network of approved laboratories. And when you post a job to labpronto.com, the job gets sent to the lab that has available time as immediately as possible. And of course, the proper education and the proper level of service. So you'll get the expedited turnaround, you'll get great pricing, and definitely keep it in mind as you get back to work, labpronto.com for the digital work.
And I agree 100%, everybody. So I teach a lot of digital dentistry and surgical guide designs, and Lab Pronto is especially awesome for the design side of things, because whether it's designing of surgical guides or ortho cases or a variety of different things like digital dentures, things of that nature, the design is a lot of times the hardest part for most dentists. So it's pretty easy to buy a 3D printer and just to say, all right, give me the files, I can do this. It's a whole lot of other work to say I can design this. So I highly recommend Lab Pronto, especially for that.
The digital work at Lab Pronto, the turnaround time is even faster. Obviously, you're not shipping anything physically, and because we give it to the lab at the available time, you could get the plan back. Usually, it could be hours, sometimes it could be longer, depending on the number of orders going through. But the turnaround time for digital work is fantastic.
Okay, so let's pause on some questions. And this is just a summary here of the entire page. So again, there's a lot of clinical factors, block versus local, tissue resiliency, pressure angulation, overheating. There are quite a few things that you do need to be concerned and worry about when it comes to the actual surgical guide type of resulting factors. So just to take a couple of moments, especially about kind of this particular case, my top list is what you see right in here: generalized human error and how that's a factor, mechanical error within the guide, and then registration of the cone beam. So this is just a quick review, just that way we cover AGD and PACE and credits and everything. So really it's just a tool in our toolbox. Do not expect a guided surgery to be brain-free surgery. A good friend of mine, a good colleague, incredible person, probably the pioneer of digital dentistry, Scott Gans, brain-guided surgery. It's true. This is not brainless. You still need to think. And even though I keep using this picture because this guy looks hilariously like me with a goatee, but I think this is just from Shutterstock or something like that. So yeah, that's a little bit weird resemblance. But again, expect error. Again, I'm a huge advocate of guided surgery. Just know the limitations. And the limitations are what you see here. This is not the best guided case especially for your first surgical guide. Super thin bone, anterior case, even though surgically it's easy to get to, but man, oh man, choose a first molar, big wide ridge patient that's pretty easy and can open like an alligator. That's going to be your first surgical guide case, because you have to think about the guide size. You have to think about the drilling length. How many of us have, placed a guide and asked the patient, all right, open up big, and you can't even place the drills in there? Me, unfortunately, it's happened too many times. But surgical guides are amazing for this particular case. Very predictable dentistry. But yeah, you got to worry about the size of the drills. But the good news is you can work around that. You can use shorter drills, even if it's just that first pilot hole drill. If you can't do the case fully guided, know when to step away and to say, listen, I did all this work just for one drill. It's still worth it, everybody. That pilot drill is 80 to 85% of your final implant position and angle. So you get really predictable dentistry with this. Operator experience is important. So make sure that you reach out to the network of experts, especially here at Blue Sky Bio, incredible people that are pioneers in guided surgery. And many of them, just incredible. It's too many people to mention, but incredible people at Blue Sky Bio. But mechanical errors is part of it too, because there's a physical act of drilling. And as this question's come up a couple of times, tolerance of that drill in between the surgical guide is absolutely important. How that drill contacts through the guide tube and how tight it is a factor. And it's interesting too, because there are some clinicians who just like it really, really with a lot of play. And there are some clinicians who want it super tight where it doesn't wiggle at all. And we all want it to be precise. We all want it to be accurate. But the key is that sometimes inaccuracy is out the door if you can't get the drill through the tube, or if you drill and it's too tight and it binds on the tube itself. That's a problem. And then this is a very simple method of how all surgical guides work. Basically, you have a total drilling length of D, and then we have an offset and prolongation that gets to it. So the idea is that we need to compensate for that. Blue Sky Bio figures this out for you, but it's important to understand this, because even in the software, you might say, well, this one particular case, I want to tweak it just a little bit because maybe the guide tube is too close to the bone, too close to the tissues. You're going to back it up a little bit. There are times to know that this calculation formula works. Do also understand that there is potential angulation error. Shorter drills are better, in my personal opinion, than longer drills. So if I can make the guide tube a little bit closer to the tissue, better. I do not like reduction handles or spoons. I just say, get rid of them. I don't use surgical guide systems anymore that use these unless I absolutely have to. Longer implants, why? Why does that happen? It's because when I have this thing and I'm holding on to the guide and I'm going like this and then drilling through another thing, it's like 10 things I have to hold. And then you're leaning on it because you're concentrating on drilling, that it causes the guide to tip up a little bit. What a mess. Longer implants increase the chances of deviation, of course, and increased distance between the guide tube and bone also increases potential error. Also know the bone shape and profile. If I have a bone that's big and wide ridge like this, that's a perfect guided case. A ridge that looks like this, where you want to drill right through that point, maybe open up a flap, take a rongeur and just nip off that point just a little bit and then put the guide on. I don't know, getting a ridge instead of looking like this, maybe looking like this. That's the way to go, because the drill is going to deviate towards the path of least resistance. And the least resistance is not the sharp pointing crestal bone on the top of those super thin cases. Drill wobble is a significant factor. Many people do believe that the wobble of the drill within the tube itself can be a huge factor of inaccuracy. And when you have so many drills in traditional guided, fully guided systems, that's a factor. So do consider that. And final couple of just lecture slides, and then we'll get back into case planning. This is why I went back to the slides, is because registration of the optical scan data is absolutely important to understand, because it's seemingly simple, but in fact, it's actually relatively complex. So the folks here at Blue Sky Bio came out with this incredible algorithm. It just goes, and it makes it look amazing. But it really is important, even though with automatic algorithms, that we use our eyeballs to check, because we must trust our systems, but validate them. Okay. Because what happens is that you see on the left-hand side of the screen, pretty accurate alignment, and on the right-hand side of the screen, inaccurate, because we're looking here at this little yellow line. This yellow line is in the Blue Sky Bio software, or green or blue or whatever the color of the model is. This line is the critical part. And we have to use a cone beam scan that separates the soft tissue to see this perfectly. We have to resist the temptation of telling the patient, stick your tongue in the roof of your mouth, because if the tongue was up here, you wouldn't see any of this outline of the patient's soft tissue on the palate. I place cotton rolls on the buccal of the teeth for the upper or potentially the lower or both. And the reason why I do that is that it creates a pocket around the teeth. And it does help with a little bit with metal artifact, things that get in the way, so you can minimize some of that radiation scattering or photon scattering. But what happens is it's really all about making sure that you keep that gray right here, this gray of the lip, away from the gray of the gingiva and the teeth, or the white of the teeth. Visually, it allows us to see it. So huge amounts of error is potentially possible with just the registration step. And that's why I wanted to talk about it there. So when I'm doing that, this part is an absolutely imperative, super critical, probably in my opinion, the most important step of your entire guided design, is going through your software. Once I've taken that scan in now, brought this in here, it looks good. Man, oh man, automatic, everything looks good. In this particular case, it does auto align perfectly. Okay. How we verify this is using our sagittal slice, which is this top left box. You use this little double arrow right here, and I'm going to left click that little box, and I'm going to use my mouse wheel to scroll through this. And I'm going to verify that I can see this green outline and this kind of tooth outline. And it's going to allow me to check all of that to verify that I can see the approximate outline is looking pretty good. And then you say to me, oh, but Mike, you made a full arch scan. Yeah, I did. Okay, here's what our scan looked like. I grabbed some of this palatal soft tissue. When you're using your optical scanner, make sure that you try to capture as much of the palate as possible. Do full scans. This particular case was an intraoral scan. If I'm using an alginate, don't just use a little tray that only is a horseshoe. Use a tray that you can pick up the palate as well. Why? Why do I do that? Because you can't see the palate really well here. But here's a little hack as well. In your kind of axial slice mode, which is this middle top box here, grab this little panoramic curve button, and these little gray discs or orbs, make this bigger. Whoa. Now I can see a whole lot of the palate. So now when I go back to this box over here, I can see in this kind of sagittal slice this entire palatal surface. And I'm looking at this green line covering that aspect of it right here. In addition, I go back to the axial slice, make that big, and I'm going to go through the axial slice right here at the cusp tips to make sure that that green line is outlining this patient's teeth really well here as well. And that part is absolutely critical. I'll take another pause here for a couple of questions. This guy's amazing. Daniel May, you're fantastic. He's a great guy. So I'll take his question here. We have a CEREC scanner. Oh, I'm sorry to hear. No, I'm just kidding. It's a great scanner. We have a CEREC scanner. Can its file be integrated with a non-CEREC printer? And the answer is absolutely. Starting with CEREC software, I think it's 4.50 is to my knowledge. They were giving you the full capability of exporting STL files. And that's really done incredible things for the CEREC community because, you know, as of before, CEREC was a totally closed scanner. You would have to like send your DXD files or whatever your CEREC files to a CEREC in lab, and then they would need to convert it and do all this crazy stuff. But in all reality, now you can easily just at the model phase of your design, easily export your STL files. So that was a great question. A couple more questions. Great question here from Fareed. What PVS material do I prefer to take an impression with for a dentate patient in order to do impression inversion with the Ferguson technique so we can get an accurate inverted model for a patient? Great question. I'll defer to Rick Ferguson, who's an incredible person, an incredible mind. He's come up with some incredible things. You know, to my knowledge, what Rick recommends is pretty much any impression material, but you have to use a plastic tray. That's my understanding. Rick, you chime in if you're here, or we can reach out to Rick on the Blue Sky Bio forum if he has a preference. But I think he would probably say putty impression material and a light body wash. That's a guess. The reason why is just because it has a little bit higher density. That's a guess. I don't really do that technique in my office just because personally, I use that technique a lot, and I ran into some issues where if you have the lightest amount of cusp show through on the impression tray, then the way that the cone beam scanner would interpret the impression is you would have a positive error. So there'd be a lot of extra scatter, which is fine because it's still better than negative error, because when you make the surgical guide, it'll still fit on the patient's mouth. But to my knowledge, what I would do is just pour up the impression in a stone model and then take the stone model, put in the scanner. I personally, that's what I think. But if you're using PVS, as long as you don't have any cusp show throughs and it looks like a good impression, you can totally use that. You can even use alginate. You can use alginate to scan alginate impression in a cone beam scanner. Just make sure you don't use a metal impression tray. So that was a really, really good question. But again, some of those questions I'll defer to the expert, Rick. He's been doing it for so long. He's really got it dialed in. So I encourage you to reach out to him as well. Okay, so let me jump back into this. We'll take some additional questions here in a little bit. So once I've got this case kind of put on, the most important step, as I mentioned before, is verifying that the stone model alignment is clean. For some reason, if I don't like how that alignment looks, what you can do is you can come in here and you can change your alignment functions. How did I get to that? I apologize, a little bit tricky here with the Zoom software, so I'll kind of make this a little bit smaller for a second. I open up the Blue Sky Plan software, come up to the top where it says panels, and then you can just go right here to your model editing panel as well, or you can go to your registration panel, model manipulation. So you can do it in one of those two functions. So the model editing allows you to go ahead in here and you can go ahead and close holes. You can also smooth out the models. This is the point where you can do some of your virtual extraction in Blue Sky Bio software, but to change your registration panel's model manipulation, and right in here, you can choose which model it is, which is the Scan EXT. Make sure it's chosen here as Maxilla. And then I can come in here and do any one of these alignment methods. I can click on Model Manual, which allows me to go ahead and physically manually move it around. I don't recommend using that unless you're pretty experienced with the software, because you can make an error, but I'll simulate an error really quick. There we go. And maybe I'll do this also. Holy Moses. Yeah, that would be inaccurate. Hold on. Thankfully, Control Z exists, in all software. I'm going to do it this way. There we go. Now, this is going to simulate an error, okay, as the registration did not register correctly. Okay, so maybe my scan did not register correctly. And you'll notice here that when I go back into my sagittal slices, my green line is way off. You can see here the cusp tips are not on. Everything here looks kind of messy. The go-to method, in my personal opinion, of aligning CBCT scans with optical scan data of stone models, et cetera, is to use this points mode. So right in here, left click on where it says points, and then if the automatic alignment does not work properly, this is my go-to. And this becomes very important when I'm using scans, like using radiopaque PVS impression scans, like with the green mousse impression technique or the radiopaque PVS impression technique, which is basically relining the denture with radiopaque PVS. And when I do that, two boxes appear. And the idea is that I'm going to kind of position the teeth and look at it from the CT data versus the optical scan data. And when I do that, I hold the shift key down. When I get close, hold the shift key down, and now I can define an orb on each individual cusp. The reason why I make a cone beam scan with soft tissue separation with cotton rolls, and then also an open bite CT scan. Open bite always. Why do I do that? Unless I'm doing this crazy stackable nonsense. No, I apologize. I shouldn't call it nonsense. It's amazing stuff, but it's very, very complicated. The vast majority of my implant surgeries are very, very boring. Single implants, overdentures, which I love. Okay, I love boring implant surgery. Okay, the vast majority, 99%, 99.5, 99. I don't know what it is. So for my assistants, I want to maximize my systems in my office, meaning my office systems. My assistants are trained to do cotton rolls on the upper or lower, depending upon where I'm doing the implant. And then they always put cotton rolls to separate the bite. The reason why I want to separate the bite on my cone beam scan is because of this. I can see that lingual cusp, that mesial lingual cusp perfectly between my optical scan data and my cone beam scan data. If the patient was biting down, I wouldn't be able to see it. I could use buccal cusp, but I don't know. Why do we need to have the patient biting into centric on the cone beam scan? The only two reasons that I've ascertained, please correct me in the comment section or the question and answer if I'm wrong, but the only two things, the reason why is number one, if you're an orthodontist or you want to do orthodontics and you need to see cephalometrics from the cone beam. Okay, good reason. Second reason, stackable guides, because you need to rely upon the patient being at the proper centric vertical position off of your cone beam scan data. And that's even optional, because if you have intraoral scans at the correct vertical, you in theory could reorient some of your STL data within Blue Sky Bio, but it's a whole lot easier if you just have the patient biting down in the centric. So two reasons: orthodontics and stackable guides. So when I have an open bite, I can then say, look here, this is right there, mesial incisal edge. And then right in here, I've got a perfect lingual cusp right there. And then finally, a very nice distal lingual cusp. Even if my patient has a lot of amalgams or is heavily restored, like I got a lot of scatter back here. It's not a ton. I'll bring up another case in a little bit where we have a little bit more crowns. But you can see here, I define, somewhere between 4 and 6 points. I typically like 4, just keeps it simple. And then click the OK button. Also, this down here at the bottom in the Blue Sky Bio software, do know that you have two options: refine using ICP, which is called the iterative closest point algorithm, or refine using best fit matching. So there is a difference between the two. I will defer to the people that know this a whole lot better than I do. But the idea of that is you can toggle between those two settings depending upon your scan data. So if I'm doing a 360 denture scan and it's a radiopaque PVS appliance, typically I'll take off some of those algorithms because it can get in the way of the alignment. But for a simple case like this, it's pretty simple just to leave everything as default. Best fit matching is a wonderful way to align those. And then I click the OK button. Blue Sky Bio will correct that alignment. So I know I spent a lot of time on alignment here, but I'm going to tell you the truth, everybody. Alignment is such a huge, important thing, especially with some of these challenging cases when you start getting into heavily restored patients. How would I align a heavily restored patient? Sometimes it's just a raw guess. But if you have the entire soft tissue appearance and I have a full scan and I've got all these shiny gold crowns, but I can align using this little arc right in here of the palate. Or on the mandible, maybe I've got tori down here on the mandible or retromolar pads, things of that nature. You can do some impressive cases with the Blue Sky Bio software, but opening your mind a little bit. That's it. And that part's very, very important. And I'm going to carry on. So let's go ahead and finish up the planning of this case because I want to jump to some other cases as well. To get our implant planned in here, pretty simple. Typically when I plan an implant case, also everybody, I change the rendering of this little box down here. I just click on this little kind of skull thing, presets, and I click on non-shaded bones. I just like it. It just kind of looks cool. I think this is my favorite mode to work in as opposed to some of the other ones. Just kind of looks like you can see the roots, you can see the implant once I drop it in there. So now at this point, I can go ahead and what's nice about the latest version of Blue Sky Bio software, I come up here to the top where it says continue to implant planning. I click that. And then it gives me, if I want to add a nerve or do whatever. I can also go back into the wizard function. You can jump between wizard and expert mode per se, or wizard and standard mode, depending upon what you want to call it. But I'm going to come up here to the little plus icon with the little implant. And then I'm going to choose the implant I'm going to use for this patient. So this particular patient, let's go ahead and simulate using a Blue Sky Bio Max implant, which is an amazing implant. This particular patient, I think I have right here, I written down, oh yeah, I used a 5.0 by 13, which I know is a little bit crazy to some folks that use these super small implants and super small platforms, but I don't know, man, I like them big and, just sharp and sometimes a little bit longer. Don't read into that. So anyways, I'm going to click on this part of the scan and usually it kind of drops in the wrong position. I probably should have done it over here, but no big deal. I just grab the implant and I drag it right into that position. And then I'll angle the implant using this little orb and just kind of get it about into the right position. And what I do is in this upper right portion of the scan is what's called the implant tangential mode. If you can't see this, one thing that's very important to kind of reset everything in Blue Sky Bio software, especially as you play around and learn it, come up to view, click on perspectives and click on implant tangential 3. And that'll kind of reset your screen so it looks like mine. And I like putting my implant in this kind of position because it allows me to kind of get the approximate position of where the implant should go. And then what I do is I come over here to my sagittal and I just roll my mouse just so that way I can see it in that approximate position. And then what I do is I come into here into the implant slicing mode and just kind of take a look at it. And I can use this little slider to kind of just see approximately how it goes down the root structure. I'll use my mouse wheel and scroll around. In this particular case, what I want to do in this case is bring this implant so that way it follows the root anatomy fairly well, approximately like that. And I'm pretty satisfied with how that looks. What helps me also is personally, also one thing I like to do is when I'm in my implant planning, I click on the implant list. And at this point, I'll define what guided system I'm going to use. In this particular case, I'm going to use my Blue Sky Bio, not direct cut, but I'm going to use my fully guided surgical kit. So I'll select that. So that way now everything I do is set. Also verify that I'm in my advanced modeling. I personally like the advanced mode for pretty much everything I work in Blue Sky software, but come up to module, surgical guide, and click on advanced. So that way now I can see all my guide tube dimensions. Also in my implant list, I can go ahead here and look at my implant length, look at my numbering. You can add different labels to it. So, if you wanted to, what you can do is you can change the label, IDs, things of that nature, depending upon the implant system you're using. You can add a label if you wanted to, but I usually leave everything pretty basic just to get the case done. My routine cases, I click this abutment down here and I hit the replace button. What I like to do is come under my abutment, click on custom abutment, and I add a 15 millimeter long by 2 millimeter long custom abutment. And all this does is it kind of gives me this little yellow line, which I know there's this gray line showing me my path of insertion or the long axis of my implant crown, whatever, but it just kind of allows my eyes to see the position of the implant in relation to the 3D model a little bit easier. Once I have the alignment of my cone beam scan, my implant is about in the right position, I just go ahead and I turn off my 3D scan of my cone beam. It just kind of gets in the way. I don't really need it anymore. My alignment is confirmed. I've looked at my root anatomy in 3D. I feel comfortable moving forward. Then what I'll do is come in here, do one more final check to make sure my implant is about in the right position. How deep should my implant go? Totally up to you, your philosophy. This particular case, I'm only going about 1.5 millimeters below the crest of the bone. Yeah, you can follow some of these recommendations about relating your implant position to your CEJs, your papillas, whatever. You could do that if you want to. Me personally, I don't know, just get the job done. So I do like a little bit on the deeper side. I think it's a little bit kind of crazy when people are putting things 20 millimeters deep or whatever it is, but it works. Impressive case results from folks that do that. I usually put my implant somewhere right around 1 to 3 millimeters below the crest for immediate extraction sites, just because you will get some bone dieback. That is important to know. So once that's set, then I come back over here to implant lists and I turn on my copper guide tube. And this is just giving you a visualization of what the fully guided surgical kit guide tube looks like. I know one question that comes up all the time is, oh my gosh, what is this green thing? You know, this is showing up on my screen. This is for the Blue Sky Bio direct cut drills, which is a pretty amazing kit. The idea is that you print a guide with this little kind of C-shaped collar. So that way you just take the handpiece and it just goes into the collar and then you just drill. Makes it very, very simple. What I found from experience is you just come up here, just click on fully guided kit. So that way I can just go ahead and use the settings for the Blue Sky Bio fully guided kit, which is a really fantastic kit. So now I'm pretty much done with my implant planning. I've checked everything. The alignment's good. Now I'm ready to go ahead and go into the guide design. And I'm going to finish the guide design. Then we'll take a few more questions, of course. So at this point, I pull up my guide panel, which if you don't know where it is, come up to panels and click on guide fabrication. A couple of pro tips here, especially to avoid some mistakes. Make sure that you have the model that you want to work with. So if you're working with multiple models, make sure you choose the one that you want to work with. Make sure you click on this button that says lock implants and virtual teeth. I just love that thing. So that way I don't accidentally move the implant as I'm drawing the guide. Then right here, I don't know, guide quality, normal, high, very high. I don't know. I've always been kind of a medium pizza type of a guy. So high, it's in the middle. I leave it to the experts at Blue Sky Bio to kind of talk about the differences between those three. I would assume it's mesh density. So most people, I typically tell them just to recommend high. That works. You can always just use normal too. That works perfectly fine. I think that's not even necessarily worth talking too much about. But make sure you choose maxilla. And then before I start drawing the guide, blow your screen up big and then position it so that way it's easy for you to draw. Some people start like this. Other people start like this. Completely up to you. I left click on draw curve, hold the shift key down on my keyboard, and I'm just going to start drawing the curve. When you let go of the shift in the latest version of the software, it starts automatically putting the orbs, which is amazing. Okay. Then you continue drawing your curve. Usually I'll grab that first orb, come back over here, let go, move, let go of everything, hold shift, go back to that first orb, and then you can connect it. Or you can just draw a line like that and it will automatically connect them. Let's talk a little bit about guide design, because guide design is important here also when we're thinking about minimizing error. I don't like excessively big guides. I like a surgical guide that covers 1.5 to 2 millimeter, or 1.5 to 2 teeth, mesial and distal. I do not recommend taking the surgical guide in every case past the midline, making a monster guide, doing all that stuff. You know, I totally get the philosophy with people that like that. I personally think that the surgical guide, you have potential errors for going past the midline. So let's talk about another potential error and avoiding this kind of mistake. In a case like this, why I chose this case is it's a great example of why I wouldn't take this guide past the midline. Look at this patient. He's a bruxer. He's got these chipped off little things right in here. He's got a giant diastema right in here. So if I take the surgical guide all the way over in here, number one, I have to worry about the surgical guide going into those diastema areas. Yes, Blue Sky Bio blocks it out pretty well. Okay, but it enters a potential error into the equation. If you print your surgical guide and you want to go ahead and do big surgical guides, perfectly fine. But what I found from experience is that I just kind of keep it simple, 1.5 to 2 teeths beyond the implant if you're doing a single implant surgery. And then number two, also the thing that comes up too is this assuming that you have an intraoral scanner. Anytime that I pass the midline, there is a potential for slight inaccuracies. It's especially evident in older scanners, like the original iTero or the original CEREC scanner, which are perfectly good scanners. But when you cross the midline, there is some more potential for inaccuracy. So I just like this. I think it's also less costs, simpler, and I feel you get enough stability during the surgery to do that. So once you're done with that, click on your draw curve button, then click your create surgical guide button. It goes whoop, and then it starts processing. So at this point, let's take a little pause. I'll bring up our chat window again here, question and answer, and let's talk a little bit, everybody.
Can you just comment? A question that we get frequently is the intersection that we see on the screen between the software guide tube, that brown circle, and the adjacent teeth. Is the situation that you have on screen okay? Is it problematic?
Yeah, that's a great question. So I'll kind of dance around it a little bit here, just so that way once we finish the guide, I'll move the tube around. But looking at the screen, that's a great question. When I see that copper tube, if the outside part of the copper tube is intersecting to teeth, I'm okay with that. If that inner tube is intersecting with teeth on either side, you have to be very careful. And if you're doing a metal push tube and it's going to be going into this surgical guide, and that is touching the inner tube, this little inner hole, this one right in here, if that's into the adjacent teeth, then it will prevent you from fitting your tube straight out of the package. Now you could take a burr, cut the tube, or you can go ahead and modify your tube virtually to correct that. Another reason why I like, in this particular case, sleeveless is that I have that flexibility. Although this case, I could have absolutely used a metal tube for this particular case. Couple things, avoiding that mistake. So metal tubes are awesome. Okay, I use them all the time. If I am running into that issue where that little copper tube is intersecting to adjacent teeth, or more commonly intersecting with the soft tissue of the model, you can modify your implant position based upon your anticipated guide design. Typically, I don't want to change the angle of the implant too much because I'm setting it ideally. But if you can wiggle it a little bit, the differences between 2 degrees this way, 2 degrees this way is not really going to be making that much of a difference. However, if it's too deep, which is usually more common for most systems, you can arbitrarily change your offset higher and just choose a longer drill for the surgery. So case in point, if I'm pulling out the Blue Sky Bio fully guided kit and I want to put in a 10 millimeter long Blue Sky Bio Max implant, I can choose the 10 millimeter long implant in the kit, okay, or in the system. And what I can do is I can bump up the offset or drop it back down, depending upon if I want to use a longer implant or shorter implant. So in theory, the surgical guide is actually going to be clinically making me drill a little bit shorter versus my plan. But you can compensate for that by using a longer drill on the day of surgery. It's a little bit more advanced concept. It's not for the average user to do that, and I caution you with that approach. I'll show you once my surgical guide is finished designing. It's a little bit slow for some reason just because I'm zooming here. But one important step of finishing your surgical guide design is checking your lengths in the measuring tool once you design your surgical guide. Okay, but that's a wonderful question. So let's see here. Okay, there's my surgical guide. Perfect. Now, if I can go ahead and just check this. I mentioned just a moment ago about checking this. This is important. So I'm going to minimize this a little bit. And now what I'm going to do is just going to kind of take my boxes, make those kind of go to the side for a moment. What I like to do is it is very important that once your surgical guide has been designed, I, number one, go up to my surfaces panel and just turn off my panel for my teeth. And I also need to turn off my copper guide tube. And this is going to show me my surgical guide before I export it from the Blue Sky Bio software. So let's take a look here. I can see nice, clean surgical guide. Everything looks blocked out. If you sometimes in the system, and maybe your scan, your optical scan, you've got like a little hole in your optical scan. So maybe there's a hole in your scan. Sometimes what will happen is that when you design your surgical guide, you might get a little thing just going sticking out of this part of the guide. What you can do is to avoid that. When you export your guide, you can do a quick repair in Mesh Mixer, or you can just print it as is and take a burr to it, or you can go back, clean up your model, close it using your model editing functions in the Blue Sky Bio software before you make the surgical guide. Also, taking a look at this guide, you can make an argument that this guide would actually be, I need to go lock my implant because I'm moving things around. There we go. You can make an argument that this case would actually go better if I used a metal tube. What do you mean by that, Mike? If I look at my surgical guide here from the side, it's very thin right in here. So I'll blow this up a little bit bigger. It's very thin right in here. If I had if I do this with just sleeveless and I start drilling through that little fin can just go and break away. If I had a metal tube on there, it'll probably be a little bit more stout than using a sleeveless. So pros and cons of using both. I use both, pros and cons. So trusting but validating, going up to the surfaces, come up to where it says surgical guide and turn on your hint right in here, this little checkbox. Now I can see the outline of my surgical guide in that blue right in here. And what this is going to do is it's going to show me my position of my surgical guide in relation to my implant. Before I export the surgical guide, I take my ruler here at the top, and I take from the top of the implant, I bring it all the way up here to kind of where my length is. And what happens is that in the Blue Sky Bio software, you don't need to worry too much about this, okay? Because they have a prolongation that's basically set. Now, the idea is that I can take this and measure this from the top of the implant, which if I do it like this, to the top of the guide, you can see here that my total prolongation from the top of that little tube is 21 millimeters, which is correct for the Blue Sky Bio system. How do I get to that number? Say you're using another guided system. How would I trust but validate that? Take out your measuring tool. And then what I'm going to do is I'm going to take the length of this. Okay, it's a little hard for me to do it at the same time and show everybody here on the screen. But I'm going to take the length of this from the edge of the drill to the tip. This little flat portion right here of the Blue Sky Bio kit, that little bottom edge right here, this, I'll point to it with my little tool, this little part right there. That's where the drilling action occurs, per se, virtually translated to the drill. So now when I take that and measure here to the tip, I get approximately 21 millimeters. Approximately, it's a little hard to see on the screen. Okay, 21.75. Okay, so that's a important, trusting, but validating step for my eyes. Okay. And that becomes very important when you're reverse engineering other guided kits. So say you want to use like a Hyosin or One Guide or whatever kit you want to use. That's a very, very smart way of doing that. So let's answer some more questions. Good question, Paul Rains. How come you do not use a virtual wax-up for the tooth? Is it possible to do a virtual wax-up on a Blue Sky Bio? Absolutely. Me personally, if you're going to talk about kind of like what's a great fundamental way of beginning, I'm assuming that most people tuning into the webinar are somewhat experienced with Blue Sky Bio software, just coming in just to avoid some rookie mistakes. But what I teach in my courses too is I always start with the crown down philosophy, meaning start with the restoration in mind and then work from there. I won't go too much into that because I want to get into some additional cases here. But yeah, it's really easy. Just come on up to here. I just need to move this. You literally just come up here, add tooth, and you can just add a virtual tooth in here using any one of the libraries that are available in the system. So I'll grab a first premolar, medium, and you can even align the tooth to the existing implant, click OK, and boom, there you go. You've got a tooth. And then you can, move the teeth around in your tooth manipulation mode. Alternatively, what you can do as kind of an advanced technique is, this looks kind of crazy and silly in here. If anybody in here is working with exocad, or you're working with any other softwares that's like dental specific, or you can even use the Crown and Bridge module in Blue Sky Bio, et cetera, you can literally design the entire final crown and then back your implant design in there. And even where I come under implant list, come under abutment, I can add in one of the Blue Sky Bio actual abutments. So I can come into here and add in the tie base or whatever you want to use. So you can use a variety of different implant parts to be able to go ahead and have prefabricated abutments. Say you even want to go ahead and have the tie base. So I'll put the tie base on here. So now you can see the tie base in that position, and you can go through and actually then design the immediate temporary to go onto the case. Personally, I don't know if I would, I don't design the temporary to be on a tie base for the day of implant placement. However, this is a wonderful technique, is using one of these longer, here you go, like one of these temporary posts. Okay. You can use something like this, or not a locator, but you can use whatever one of these components that are in here for your planning purposes. So the idea now is that we'll use the little temporary post. And then you can go ahead, I'll just use that's for the multi-unit, pardon me. There we go. So using a temporary post or whatever you want to use, you can bring this in here and change it around, and then go ahead and pretty easily be able to go ahead and punch out just a hole in this crown. So that way you can 3D print your tooth crown with a hole on it, then you can pick it up in the mouth using the actual post or the tie base.
And if
That's
I
a
could
great
just add
question.
a comment, so today in the software, you could align the scan bodies, you could do the whole crown design, print the crowns, and our upcoming release, which is coming out pretty soon, has the ability to export the XML config file to the milling machine.
Awesome.
So you can mill the crown, the temporary or the final, and that functionality for designing, exporting, and milling the crowns from the Blue Sky Plan software is going to be offered at no charge. So you'll be able to
Incredible.
design unlimited number of crowns, export it, print it, or mill it, and you'll be able to do that at no cost.
So we have some other questions here. That's a good question. So here's a good question from Mohammed. Is more coverage better accuracy, or is that not relevant? So I assume talking a little bit more about the intraoral scan or the optical scan data. So the answer, in my personal opinion, is that the more optical scan data that you have, the more reliable your guided case planning will be. That's my personal opinion. I know some people would defer with that, but certainly that it is an issue as well. A couple more questions here. Let me see here. This is a great question from Dr. Hong, I think overseas here as well. Welcome and join us. Hi, Mike. When you raise the flap, do you design in any spacing within the guide to accommodate the reflected flap design given in that guide? Oh, great question. So if I'm doing this case with a flap, that is a concern. Okay. So what you can do, that's kind of a cool idea. So I'm going to come into here. Let me just go into my surfaces and my tooth library here. It's going to get rid of my tooth here for a second. Tooth list. There it is. Good. Get rid of that tooth. So what you can do here is, say I wanted to go ahead and build in a little bit of spacing into this model. It's not really a way to do that with a click of a mouse button in the Blue Sky Bio software. So assuming that not in this particular case, but say it was just a standard case, which we'll do in our next case here, why don't we just go ahead and pull up that next case, and then I'll be able to get a good descriptor for that. You can. So either in the Blue Sky Bio software, or you can do it in Mesh Mixer. You can come up to your panels and go into your model manipulation tab, or into your model editing tab in kind of our other steps here as well. You can mesh in a little bit of blockout data in here, which would be essentially, if I'm going to do a flap design, I'm going to elevate the flap so that way it can hide behind the guide. Um, Another option too is that you just design your guide to be a little bit shorter. And personally, that's what I do for most of those cases. I don't go to this crazy length of blocking out space for that way, the soft tissue and all that stuff. When I do the guide, what I do is that when I do the guide, I go ahead and I design the guide a little bit differently. So if I'm going to elevate a flap, I'm going to bring up my guide design to be a little bit more up here like this. So that way, when I open up a flap, I can elevate the flap using a crestal incision and then tuck the flap around the guide. That's what I do in the vast majority of cases, and it works pretty darn well. Sometimes I'll even kind of arbitrarily, I'll pull this up and bring my tube up here. As long as I kind of keep this orb, about like so, it'll still build the surgical guide in correctly for me. So that way you just don't want to bring your guide tube up too tall. So that was a great question. You can design your guide perfectly that way, or in the software Blue Sky Bio Mesh Mixer, I can kind of inflate or build out some of that model. So that way it creates a pocket on the inside of the surgical guide. That was a really, really good question. So let's go into our next case, unless, Michael, we had any other additional questions you want me to answer on this particular case.
No, I think, there's a lot of questions coming in. I think let's go on and.
Okay, cool. So let's talk about our next case here as well. I won't pull up the slide deck here as well, but you can kind of see it here. I've got a patient here missing kind of like a partial quadrant in his bottom left. 2 implants that we're going to place, and our plan is to do implants. We'll place 2 implants, put on healing abutments or scan bodies, scan that the day of implant placement, and then we'll go ahead and have a 3-unit bridge ready for the patient 6 to 8 weeks later. And the neat part about guided surgery, this is a good punch case where I can just do a punch incision with these 2 implants here, and then put the scan bodies on the same day of implant placement, and then literally send that data to the laboratory. I've done that pretty routinely for some years now. It just really, really is a good workflow. So let me go ahead and pull this up here. I'll bring up our Blue Sky Bio again. A couple questions while software is loading up. Jose says, is the offset of the cylinder predetermined in any way by the surgical guide chosen? Offset is chosen based upon what drilling system you're using. So you notice that I chose the Blue Sky Bio fully guided kit, and that chose the offset parameters already for you. And what happens is that I write down some of these settings as well, and I kind of figured it out. And I just have like my little cheat sheet that lists kind of what my parameters that I like to use. So I recommend when you're doing this that you just write down what settings work well for you. So that way it just streamlines it for you for next time. I personally like a little bit more tolerance for my surgical guide, especially when doing sleeveless. So I write it all down. So that way, if I do modify from the Blue Sky Bio settings, I have my parameters that I like. So when I mentioned a few moments ago, when somebody asked me to say, well, what settings should I use? It depends upon what your printer is. It depends upon what your feel is. So I recommend just printing a bunch of guides using the resin. Just spend the money, just try a few different settings and find out what parameters work well for your printer, as well as in your hands. And I think that's a smart idea.
Can I just jump in here with a comment
Please.
regarding a feature that I think is less known about? When you select a surgical kit, there's an option for a custom surgical kit. And what that does is if there are settings that you like for a particular implant and you want to use it every time you place the implant, you can modify the settings in advanced mode and use the custom surgical kit. And then each time you place that implant, it will automatically bring up the settings that you used previously. So if you use a particular implant set and you're generally using a selection of implants, You could change the settings and the software will remember that, and that's via the custom surgical kit.
Awesome. That's super. I was not even aware of that. That's very, very cool, Michael. Thank you for sharing. Okay, so for this next case, I'm going to bring up his folder. So I have my cone beam data that's converted or copied over. And we're going to go ahead and bring this on up here. Just click on the open button. And what I should do here, just for good HIPAA controls, I'm just going to kind of bring this in here to make sure I cover any of the name. Okay, good. So again, for this particular case, this is important. You can see here that my patient was leaning a little bit. So I'm going to go ahead and correct my orientation this way. Until that has changed in the software, I still recommend doing this, aligning this plane to this box, this plane to this box, clicking the OK button. And again, I'm just bringing up my little notepad just so that way I can quickly anatomize the case. Oop, put that over there. There we go. I'm going to kind of click out of this here for a second. And just anatomize really quick. There we go, done. All right, nobody saw that. So anyways, so what we're gonna do now is we need to go ahead and import the stone model. Like I said, I clicked off of it so you could automatically do it, but I'm just gonna come in here, import STL data, and I'll pull up our patient scan. So just going a little bit quicker, just to make sure that we stay on time. I'm gonna click on the OK button, and here's my intraoral scan of that patient missing the 2 teeth over there. So when I click the OK button, it's going to ask me, okay, is STL data, is this a mandible or maxilla? It's a mandible. So click the OK button to align to the mandible. And while that's aligning, I'll go ahead and check out a couple more questions here. Mustafa asks, what is the advantage of a cone beam scan with an impression tray in the mouth? There's some doctors that like to go ahead and have the patient kind of with an impression tray with markers in their mouth, or the patient's mouth doing the cone beam scan data. The idea of that is so that way you can go ahead and exactly align the inverted impression scan and then have the teeth magically grow out of the impression on the cone beam scan, which I think is pretty darn clever. Me personally, I don't really see much of an advantage to that in my practice, just because number one, I use an optical scan data, intraoral scanner, no PDS impressions. So that's number one. Number two, I don't really think the idea of having a patient shoving impression material in their mouth for several minutes during a cone beam scan is that fun of an idea. But then again, it's not that big of a deal for most patients, so it works. So the idea is to go ahead and easily align the inverted impression model, which is very, very clever. But in my personal hands, what I do is just do an optical scan directly in the mouth. Okay, so I have that scan. Blue Sky Bio, again, nailed it. Taking a look here, we're going to make sure that this is aligned. And you can see here, oh man, okay, how come I don't see that many teeth? Don't forget, in your panoramic curve axial slice, grab these little gray orbs, make it bigger. That way I see a nice kind of sagittal slice. I have cotton rolls in place. Everything looks pretty clean. I can see I've got a pretty decent looking scan. Everything here looks pretty darn good. You have to be careful, everybody, too. Don't get caught up with some of these little tiny nuances in here. You can spend hours realigning scans and doing all this, but this scan looks pretty darn precise. I'm pretty pleased with this. Okay. You know, even like in this situation, I'm like, maybe, oh, should I bump it over here, make these modifications? You know, you can make the argument, I'll just turn on my manual mode. What's nice is that you just hover your mouse over here and you use your keyboard just to kind of dab a couple times, just left, right. And to me, that's a little bit better than what you saw before. So that part is important. What I typically tend to do is make sure that in the area of where I'm doing my implant procedures, that it's aligned properly. Even if it sacrifices a little bit on this other side, like it's a little bit off, just a touch, you can make that argument. And this part's important. The reason why I show the scan is because my assistants placed, I'm going to turn up the brightness a little bit so you can all see. My assistants placed those cotton rolls in there for this case, because a lot of people have trouble aligning these distal extension cases. And these can be a little bit tricky. And this will kind of help with additional people attending in that want to know about anchor pins, things of that nature. So this will be a good anchor pin case. We're going to add our implants. But importantly, I'm also going to verify that this distal extension area is clean. So I'm just going to keep slicing through. I think I'm going the wrong way. There we go. There we go. Okay, so I'm going to start here. Perfect. Okay. So I'm starting here on this tooth. Everything here looks properly aligned. Cotton roll sitting right here, cotton roll sitting right here. It's very important to make sure that cotton roll doesn't stay in the mouth for a long period of time because it starts to get saliva, which has mineral content in it. So especially like the sublingual area, you can see this cotton roll over here looks fine, but you see this little shadow? That's the cotton roll that's been in the mouth for too long. That's because the patient's been, salivating, and some of the mineral content in the glands below the tongue do have mineral content in it. So that's what you see. So anyways, I'm going to slice through, and you can see here cotton roll and distal extension as you carefully attune the eye. And it's a little bit tricky in this mode, but come up to the panel surfaces and turn off your hint. Turn it back on. And what I'm looking for is this green line corresponding to this gray line. This gray line is the patient's soft tissue of their distal extension ridge. It's visible because of these cotton rolls. That's critical. In these cases, so easy to align. Software takes care of it, but this allows me to validate it. Here's the retromolar pad right back here. Okay. As I slice forward, everything aligns very nicely. And that part is so important. I know I keep coming back to it, but now the guide is really simple to design. At this point, I can go ahead into the implant planning, and I will add the nerve here. So I'm going to go ahead and just kind of into my slices. What helps is you toggle this little X-ray icon, slice between composite view, etc. What I do before I draw out the nerve is I'll go ahead and kind of hackerize the panoramic curve to get the nerve to appear beautifully down here. So I come up to here and say, draw a panoramic curve, and then I'll just kind of see 1, 2, 3, 4 points. 1, 2, 3, 1, 2, 3, double click. And now I should be able to see the nerve down here a little bit cleaner. Nope. But what I can do is I can grab these little yellow squares and I move these yellow squares around until I can see the nerve all beautifully in one slice right down in here. And I will use the Blue Sky Bio automatic nerve tool, but this will allow me to say if I need to go ahead and make any modifications if I need to as well. I won't spend a lot of time on that just because we only have a couple minutes to finish up because we probably need to get finished up here soon. But let's go ahead and click on Detect Nerve. So I've already just magically appeared in the place of where the mental foramina is. But if you're not there, just go through your slices to where your mental foramina is, click on Detect Nerve. And then I click kind of right here where my mental foramina is. And then Blue Sky Bio usually does a really good job of automatically detecting the nerve. But at this point, now you can make modifications as necessary, but it looks like it nailed it here.
And another tip and trick, you could click on the entrance to the nerve in the 3D view.
Oh, awesome. So right in this area, if I want to detect, click right in here on that 3D view as well, because it's very, very visible right in here. Thank you. That was an awesome tip. Okay, so now once I have the nerve detected, I'm ready to go ahead and add the implants. So like before, I go ahead and change this over to non-shaded bones. So that way I can kind of see it right in here. And then what I'm going to do is figure out, there we go. Cool. Awesome. I don't know what's going on. I think it's because of my viewer. One sec. Okay. So now once I have that all set, what we're going to do is just go ahead and just drop in a couple of implants. And it makes it pretty simple. I usually come over here to my panoramic mode to drop in the implants. For a case like this, come up to the top. In this particular case, we'll go ahead and use Blue Sky Bio Max again. This patient here, I used a 5.0 by 11.5. So I click on mandible, 5.0 by 11 right in here. So go right there and click OK. And I'm just going to drop that right there, somewhere in that neighborhood. I put on that little angled abutment. That was just because I forgot to uncheck that, but no big deal. I just kind of drop it in that approximate position. Come up here to implant. And then my molar, I did a 6.0 by 11 also. Yep, there we go. I know it's going to cause people like, oh my God, monster implant. Yeah, I don't know. I just like them. So Now, once I get my implants about in the right position, I'm just going to turn off these kind of virtual abutments. As mentioned before, if you wanted for planning purposes, just to kind of do a planning purpose, I use a custom abutment, 15 millimeter by 2 millimeter long and a 0 angle, just so that way I can see the long axis of the implant. And then the same thing under this one, custom abutment, 15 by 2 by 0. Click OK. Now what I'll do is in my implant tangential mode, I'll take the implant and drop it about right there. And then I'll grab that posterior implant, roll it around. I do most of my work in this implant tangential mode just because I find it a little bit easier for my mind to wrap around because I can easily slice through individual slices. And then it gives me a quick assessment to make sure that I'm not within the nerve or anything like that. Okay, so now you can see here that I've got those two implants aligned pretty well. If I wanted to, what you can do is you can go ahead and angle the implants, change the positioning of the implants if you so choose or so prefer. So I can take this one implant and just kind of angle it a little bit to the buccal. So that way I align that little yellow line to that central position of the upper teeth. Alternatively, I could do a wax up on here if you're doing a crown down philosophy, which I would recommend for a case like this, which is what I did do. So I brought the scans into the software. You could bring in the upper as well. You could use Mesh Mixer. You could use a variety of other softwares, whatever you find most comfortable for you. Then I'll take this back implant, grab that back implant. And that looks pretty good. And what I'll do is I'll right click here, just say align with implant. And then I'll just choose that implant right here because I want to align it to that implant. And now those two implants are aligned properly. So working with multiple implants, that is a nice feature. So if I wanted to take this implant and maybe just tilt it a little bit more to the mesial, just a touch, I'll grab that and maybe just kind of bring that a little bit more to the mesial. And then I'll bring this a little bit more here. And that looks pretty good. I'll grab this back implant, right click, align with implant, and then left click this front implant and automatically aligns. That's a really neat feature. So let's talk a little bit about anchor pins here. So now I have two implants in positions. I'm going to go ahead and add the Blue Sky Bio fully guided kit. Bring up our copper guide tubes. Now I have my model aligned here with my 3D scan. I'll still leave it up for this point because when I'm adding an anchor pin in this particular case, you can make an argument, no anchor pin. You can make an argument anchor pin, but in this particular case, I did do an anchor pin. So we can go ahead and take our add implant button up here at the top. You just come up right here to pin. And Blue Sky Bio makes it very easy to use their pin. You come up here to where it says select pin. I click the OK button. And typically what I like to do is just go ahead and add it in any one of these modes. Usually I'll come into the axial mode and just kind of add it right there. Let's see if that works. There you go. The reason why I like it in the axial mode is because it drops it flat into the axial mode. Then I come over here to my kind of like slice, which is the implant tangential. I'll move it halfway out of the bone, and then I'll tilt it anteriorly till I get my angle, and then approximately right there in between the two implants. Now this part becomes important because in this particular case, my scan data, I chose this case because questions I know would come up about scan data. I don't have a ton of intraoral scan data here. Look right here. If I add this anchor pin below this line right in here, the surgical guide may or may not fit. This pin needs to be above this line. So what I'll do is I'll go ahead and change my angle in my tangential mode. So now I'm making it look like I'm looking at my anchor pin straight across. Grab the anchor pin and I'll tilt it this direction and put it up into the top portion. So that way I'm past this green line right in here. And that part's key. So to avoid some rookie mistakes here also, I don't really want my anchor pin to be too deep, too far. If all I'm doing is using it for just a little bit of flex stabilization, all you need is probably about like right there. You don't need a bunch.
and I want to make sure I turn on my guide tube for my anchor pin. The only thing you got to worry about is, can you get in there with the cheek in the way? And the answer is most patients, is they make sure, can you open really big? A part of my implant exam, one mistake to really be careful to avoid, is part of my implant treatment planning is I want to look and I document in my chart how much the patient can open up. And also I pull the cheek out to make sure that the patient has relatively flexible cheeks. So if the patient cannot open approximately 40 millimeters in this posterior, that number 18 implant, can I do fully guided? Now, in this particular case, my documentation showed no, that patient can't open that wide. But in that premolar position, he can. So this particular case, I did this case fully guided in the premolar, but I only did the first drill in the posterior. Okay, I get it. Oh man, but look, it's a punch. I don't know. You do enough guided surgery, you use that first drill, you'd be amazed how comfortable you can become. Caution, asterisk, understand your limitations, okay? Guided surgery is not a replacement for knowing surgical skills. So what I mean by that is not to sound haughty, not to sound whatever. It's just know and respect what the surgical guide is doing for you. This particular case, I was able to do the anterior implant fully guided. Using the anchor pin, all I was able to do was the first drill of that back implant. But once I had that first drill, it's to full length. I was able to do it to full length. I got lucky. Okay, on that particular case, I used the punch, which was guided, and then I used the first drill to full length. And I barely got that drill in there, but I couldn't use the additional drills. They were too big and too wide. Sometimes I'll pop the guide out, pop the drill through the guide, and then seat it into the mouth. I think that's what I had to do here. That's a risky move, so be careful with that. Also, you can kind of hold the tube to the side, or you can have the patient turn their head and then lean the drill in. You can start drilling before the drill goes through the tube. Be careful, everybody. First and second molars, especially second molars, ding, 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 red flag. Okay, so now let's talk a little bit about avoiding a mistake here. I've learned very quickly that with guide pin tubes, I try to get that tube as much into keratinized tissue as possible, avoiding that loose area down here at the bottom. It's hard to say with that last patient, but for this patient, but my last patient, imagine I had this scan and say I was doing up here. Imagine for a second, we have all this posterior teeth missing back here. I can see the keratinized ridge right in here. And this is all alveolar tissue up in here. It's that soft, spongy cheek tissue. I don't want to put the pin up here because when I start drilling through that, the cheek is going to go and it's going to completely shred and tear. So whenever possible, I try to find where that keratinized line is and I put my pin just into the keratinized tissue. Little pro tip, I learned the hard way on that multiple times and having to suture up torn tissues. It can occur here, everybody. And even if you can't do this, I've even taken guide pins, as crazy as it sounds, I've taken guide pins and put them like this. Perfectly fine, everybody. Perfectly fine. Okay, now be careful because the guide still might pump up and down a little bit. The idea of the guide pin is to resist this motion, which is what, let's see if I can undo one more time, which is what, come on, Mike. There you go. That's what that's supposed to do. It's supposed to prevent this. So if you have a guide pin vertical, just know that you don't rely upon it totally. And then also you have to be careful where the guide pin is sitting because then you got to get your drill down through there. So part of doing your own guide design is you become a much better implant surgeon by learning the shortcomings and pitfalls of guide design. Because if you go, oh man, I did that, I own that, but you learn a lot. And then you learn more about doing more implants. And then ultimately you do more implants and ultimately you have happier patients. So surgical guides, and especially learning how to do it yourself, is a wonderful way of getting better at guided surgery. So we have a couple more minutes. I do need to take off here. I have a couple of emergency patients here to see myself here at noon our time. But Michael, why don't we take a couple more questions about this case? I didn't have a chance to fully finish it, but it's pretty easy just to draw the guide and finish it up. But let's go into some more questions.
Okay, let's take a look. Why was this guide taken all the way across the contralateral molars?
Okay, so this is not the actual surgical guide. This is just the optical scan data. This particular guide, yes, I did go all the way across. I felt with this particular patient, he had short, squatty teeth, and I was doing fully guided, that I made the decision to go ahead and have the guide all the way across on the opposite side of the arch. I wanted the stability of the guide, which is a good indication for risking the guide not fitting down all the way. But to avoid that mistake, I printed the model and then made sure that the model fit on the, or the surgical guide fit on the model. And I felt comfortable with it fitting in the mouth as well.
Okay, a bunch of questions regarding implant systems. I just want to comment that in our upcoming release, we are adding, I don't know how many implant systems, but we're continuing to add implant systems. We're continuing to add prosthetic systems as well, because now the crown and bridge module is much more relevant. So I'm not going to respond regarding particular implant systems. I don't know offhand, but we are adding a whole bunch of systems. Regarding Lab Pronto in the UK, we are expanding Lab Pronto internationally. For now, it's been in the United States only, but we're adding Lab Pronto to several other countries, and we will continue from there as well. Okay. Would you, this is a bit out of the scope of the presentation, but would you recommend stackable guides versus separate guides with fixation pins for full arch patients?
Yeah, the stackable guide thing is really pretty amazing. You know, I think they're pretty cool. I just think they take a ton of time to design, and I would recommend sending that to Lab Pronto for designing, or having somebody designing it for you. That being said, do I use a lot of stackable guides? I don't. I like to keep guided surgery very, very, very simple. I've done a lot of stackable guides, and they're amazing for a variety of reasons, as you know. But most of the time, I do a lot of full arch cases for implant surgery. And most of the time, we just like the flexibility of just opening up a flap and using a pilot drill, opening the flap, and then correcting implant positions based upon what we see surgically. In addition, a lot of my cases, because of my type of dentistry, we do a lot of zygoma cases as well. So those are really difficult to do guided. So stackable guides have a purpose. Do I use them a lot? I don't.
Okay, a question that we get a lot is regarding the metal cylinders. That if you are using metal cylinders, what's the best way to keep them in place? Is there a particular glue or adhesive that you recommend or suggest? And what's the best way of doing that?
So repeat that again. I'm sorry, Michael.
You are using metal cylinders.
Okay, good question.
What's the best way to fasten those metal cylinders into the surgical guide?
Awesome question. So I genuinely don't like to use any sort of glues, composites, adhesives, or anything. I design the surgical guide so that way it's a snap fit. Sometimes you have to undersize the virtual guide tube in your software a little bit to get the snap fit. That's why I was mentioning before about printing a bunch of guides to see how this fits into your practice and your printer and your calibration and your printing settings and everything of that nature. If I have to use any sort of adhesives to glue it together, I'll just use a little bit of cyanoacrylate, just like regular plain old super glue on a brush, and just around the edge of the tube. You got to work quick, seat it. Make sure you test the seat first, because you got one shot at it, or else you got to reprint your guide. I've tried before using composites and other glues and bonding agents. And most of the time when you put them in a sterilizer or you put them in cold sterile, they'll usually wash the tube away, and then all of a sudden the tube starts spinning in the middle of surgery. But cyanoacrylate usually works pretty well, just any sort of super glue.
Okay. Do you have more time, or do you have?
I do. Yeah, I've got probably about another 10 minutes until my assistants start running in. Doctor, your patient's here. So I got a couple more minutes.
Okay. Do you have someone read all of your cone beams routinely?
That's a great question. You know, it's a significant thing. Not in this lecture, but to avoid rookie mistakes in the previous presentation that I gave on YouTube, I recommend a full FOV or field of view cone beam scan on every implantation. My minimum FOV that I recommend for myself in my practice is a 12/8 for cone beam scan. I know some people say there's too much radiation and there's a lot of liability of looking at the scan. You have to have it interpreted. Yeah, that's a legitimate thing. So I feel comfortable doing a lot of interpretation and reading myself, just because I've been looking at a lot of cone beams over the years, et cetera. But if I see something a little bit suspicious on a cone beam, I will absolutely send it to a radiologist for interpreting. I use a colleague friend of mine at UNLV, Bob Danforth. Make sure you check him out. Connect with me on Facebook. I'll get you his information. He's an awesome resource. So he reads my cone beam scans very affordably. And then also, if you want to use beam readers, and I do believe Lab Pronto also has that service. Is that correct?
Yes, that is
Yes.
correct.
So you can use Lab Pronto to go ahead and have a radiologist read your cone beam scan. So lots of different options. And if you are concerned, and you should be, if you do not feel comfortable with a potential litigation of saying, did you interpret this radiograph properly? Just pay the money and have a radiologist interpret it. It's smart. And build it
Okay.
into your fee. That's important.
The wiggle factor of a metal cylinder versus no metal cylinder.
Yeah, let me see if I can grab a surgical guide real quick. Hold on.
Just to address a different question, meanwhile, regarding tooth extraction and blue sky plan, you'll be using
one here. Let's see if this fits.
the model editing panel in blue sky plan.
Marvelous. Okay.
Extraction.
I got one more.
You could paint the tooth that you want to extract, you extract it, and then you could click and close the holes. So that's regarding tooth extraction in blue sky plan using the model editing panel.
All right. So I've got a couple of surgical guides here. First and foremost, I'm going to demonstrate with kind of like a sleeveless surgical guide. Okay, so this one right here was designed for Hyosin. So this is a one guide. So I'll go ahead and use one of the Blue Sky Bio drills. It doesn't fit in this guide. It should go down all the way. This is a good example. So these two don't match properly. So if I take this wobble, watch what happens here. See how much that drill is moving, even though I'm drilling, okay? Okay, let me use a longer drill. This is the 13 millimeter drill. I go through the guide. Imagine this is in the patient's mouth. I go through the guide and watch this. Shoot. So it's easier this way. So watch this wobble. Okay, especially before you have your sleeve contacting right in there. That's the wobbling effect I was talking about. See how it trues up once you get about right here? So in theory, it should be good. So one mistake that happens a lot with guided surgery is this, is that when you're doing these cases, okay, and you, us as, combined restorative implantologists, et cetera, and especially if there's any surgeons watching, make sure that you do not assume that this is just blind surgery. I just drill in there and it works. I've seen it over and over and over again where this goes in the mouth and somebody, a surgeon, et cetera, whatever, places this in here, just goes, oh, it's a surgical guide. It should be perfect. And they just start drilling like it's like whatever, it's sideways. They can drill sideways. Be careful. Even when you're looking like this at a pilot guide. Okay, this is an example of an overdenture pilot guide. Placing this in here, these two don't match properly, so there's a lot more wobble in here, but it's not too bad actually. Hold on, let me see here. Yeah, there we go. Okay, so when I'm doing this, look at how much play there is in here. So if I lean on it, that could be a fairly important aspect of some deviation effects that do occur. And that's why it's important to make sure that you test the fit of this for both the model as well as for your drills. So the wobble effect is significant, especially that first drill. So if you just go in and say, it's a pilot, the pilot step, who cares? The rest of it will be picked up at the end. The following drills will follow your pilot trajectory pretty close, especially if you're in cortical bones. So you have to be very careful, especially with that first drill. So that's a significant factor. And what happens is how I compensate for this. I don't know if this is the way that is kind of taught in some of the videos, but what I do with the Blue Sky Bio Kit is that I'll begin every single surgery by using the L6, okay, which is the shortest drill, okay, which is just the little punch, okay. Then I will, if I'm going to like a 13 millimeter drill, I'm not going to just grab my 13 millimeter drill and just start drilling haphazardly. I will start out with the 6, drill the initial punch. Then I'll typically go one more just for the first drill. I'll usually choose the 10, make it deeper. And then I go to full length with the 13. The reason why is then after I do that the first diameter, meaning the 2.0, so 6, 10, 13, then I just follow the 13s straight across until I get to my full diameter. The reason why I do that is, imagine this. You take that drill and you're just drilling through that guide. When it hits bone right here like this, there's a chance that it's not contacting that little portion of the guide tube. Huge potential error that occurs with that. And that's just saying nothing to do with the guided kit, nothing to do with the software. You've designed everything perfectly. The print is perfect. The surgical guide is perfect. The patient's opening perfect. It's you at that drilling step using this software. And I'm not sounding ridiculous when I say that, but just saying, you know what? Shorter drills are better than longer drills, but guided surgery is still amazing. What I'm going to do is use my shorter drills first and then step up. It's a couple of extra drills, but I found that you increase precision dramatically with that.
And connected to that and responding to some questions, and I know you touched on this already, flapless versus pulling this flap.
Great question. I didn't have a chance, maybe in a subsequent, if you want to do a couple of these or whatever, I didn't have a chance to show you kind of a full soft tissue guide, maybe in the future. But what I would probably recommend for you as well is when you're talking a little bit about flapped versus flapless, most of my implant surgeries, I like with a flap. Unless it's an extraction case. I don't know, call me old fashioned. I like very traditional, very boring implant surgery that's very predictable. Flap surgery is very predictable. You see the bone. Flapless is a little bit riskier surgery in my opinion. And I think that's fairly consistent amongst kind of the literature or methodology. That being said, if I've got bone like this patient right here, I mean, this guy's got massive bone. Look at this thing. Okay. I pull this up and I mean, I've got, you know, big old wide bone. Okay. Now I don't have a ton of depth. I mean, if I over drill, I'm going into the lingual cortical, into the, you know, sublingual space, but I mean, bone width, he's got massive bone width. So the chances of you deviating here is very low. In addition to that, look at your cone beam scan. Okay. So it's very important. This cone beam scan, this is important to look at. So let me take this and I'll just do a quick little thing that I usually do when I do teaching here. I'm gonna take this. Oh, I got to get rid of that guide tube. Hold on. Oh, there we go. So what I do, I'm going to take this, I'm going to take a little screenshot. Okay. So right here is your bone. Okay. Right here is your soft tissue, that green line. So when the drill comes down, and imagine this is my drill, and it touches like right here, it's just dropping right into that pocket of where the potential implant's going to go. So you go straight down very predictably. But if I come forward a little bit, let's see here. Right here, perfect, okay. So I come forward a little bit and say, give me 1 second, I just gotta check with my assistants. I'll be back in 2 shakes.
Okay, let's see if there's other questions here that I could field until he gets back.
They're still taking an x-ray. Okay, so in this particular situation, this part's critical. So if my implant is say going to go, let me see, I don't have the implant in that position. Let's see if where my implant's going to go. No, it's where my guide tube's going to go. So imagine I want to place my implant here. All right, that's where my implant's going to go, somewhere like that. This is the bony ridge right in here. That's the bony ridge, okay? The green is the soft tissue. So if I'm drilling here, right at that point, there is a chance, now this is not a great example of this because the ridges that are like this, that's where you really got to worry. But in this particular case, that drill is going to deviate this way or this way, one of those two directions. Because when it reaches that cortical bone, especially when you're looking at, say, drills that look like this, okay? You take a drill that's this shape, it's going to deviate a little bit easier than if you have a drill that is like a lance drill, something like this. So what happens is that you also have to understand what guided system you're using and what the first drill looks like. So sometimes what I'll do is that even before I use the guided kit of that particular system, implant system, whatever, is I'll take out one of those like a Lindemann burr or whatever they call them, the little lance thing. It was like a Ben-Hur burr. You take out one of those burrs or drills. Okay, I'll be right out. You take one of the drills and then I do my initial punch. And it's not guided, but I'll take my tube and I'll just drill with that lance burr right through the center. And then I'll follow that up with my fully guided drills. Lots of different ways to do that. So that part is absolutely critical. So that was a really good question, Michael. So I only probably have about another minute or so, so I'll take one more.
Okay, your feelings on scan appliances.
Great question. A scan appliance is a very effective way of doing full arch cases. One thing that I've done before here too is that I do believe in scan appliances. So this is an example of a scan appliance. I 3D printed a proposed restoration wax up of a patient missing all their teeth on the bottom. He basically broke off one of his abutment teeth, etc. He had an existing partial that I scanned in using my intraoral scanner. And then I 3D printed this little try-in resin. There's no radio-opaque barium or anything that. I personally think that radio-opaque barium should be dead. There's no reason in my entire mind to ever think about using barium sulfate ever again. That being said, there is a purpose of using like gutta-percha points, shear mark markers, but I think what I like to do is I like to take radio-opaque PVS, realign the patient's prosthesis, then scan that in the cone beam scanner. And then those become radio opaque markers, which is visible right here. There's a little dot right here, a little dot. So those become alignment markers that I can use in the Blue Sky Bio software. Also, what I can do is I can cone beam scan this prosthesis, if it's the patient's denture, et cetera, and you can use that. Blue Sky Bio also sells a bunch of markers on their website, which are also pretty awesome, that you can just go ahead and take a little bit of glue, stick it right to the edge of the denture and work with it. A scan appliance is critical for full arch cases. I've started using less and less of them over the past 10 years or so. However, there is still a need for full arch cases, but I showed this case right here because some people would argue you need a scan appliance also for this. Historically, 15 years ago, I would take an impression, wax up barium sulfate teeth on some appliance, put it in the mouth, scan the patient, then remove that, scan a cone beam scan, both the patient wearing it, and then remove the prosthesis, put it on the cone beam scanner, and then cone beam scan that. Whew, thank goodness we don't have to do that as much anymore. There is value in doing that. It's just a classic way of doing it. But the Blue Sky Bio software is so powerful. You can take this and use this as alignment functions within the Blue Sky Bio software really natively. Really, really simple. So if you are using a scan appliance, it's good. I also make an argument that you don't need it. If you want it very safe and predictable, however, good classic safe predictable methodology, like good classic boring implant surgery is very predictable. Good classic boring radiographic markers, duplicating the patient's denture into clear resin, putting gutta-percha, shear mark markers, or glass beads. It's extra steps, but it's very reliable. So if you're kind of new to full arch cases, use a radiographic or radiographic PVS appliance or some sort of template. It's smart.
Can you bring up your last slide for a minute? I saw you had your contact information, your Facebook page. Okay, great. So we're just going to wrap up. And Dr. Scherer, thank you so much for the webinar presentation specifically. Thank you for all your educational initiatives. And we're not going to keep you tied up. You have to go. But thanks so much for the presentation. Thank you, everybody, for attending. And we hope to see you all at future webinar presentations. And if you watch live, the CE credit will come directly to your email account. You don't have to worry about that.
Well, Michael, thank you. And thank everybody at Blue Sky Bio for me as well. And I thank everybody for tuning in. We had some really great questions. I apologize if we didn't have a chance to get to everybody's questions. But if you have any additional questions, reach out to me on Facebook. I am always on there, sometimes to a pathological level. With that being said, it's really a pleasure. And I hope you, your family, and everybody stay safe during these crazy times.
Thank you. Thank you, everybody. Take care.